Well, hello guys. Hello, good evening. I hope my voice is clear and my video is clear. Yep, please put up some messages so that I can understand that my voice and video are clear. Please. Yes, is it clear? Yep. Okay, yeah. Thank you so much. Thank you so much. So, welcome to this recall session, a quick session as per your pharmacology is concerned. Yes, I can understand the difficulty, buddy, because every 45 minutes you have to complete one exam, and immediately after that you have to switch on to the next exam, even without a small like a delay or a break in between. You can understand the difficulty because previously we used to have 200 questions, and totally there will be totally of 3 hours. Totally there is going to be around 3 hours, but now we're just splitting up into 45 minutes, and every 45 minutes is appears like a different exam. At last you have finished, and say kudos to yourself, right? You guys are awesome, seriously, because if I was there in your place, I would have gone mad, buddy. Seriously, I would have gone crazy because thanks a lot that I have finished all the exams long before, even before these kind of gimmicks are yet to be happening. So let's start with the first question. Again, this is just thank you, Seema, thank you, Dr. Zeni, thank you so much. So there's just a small recap of those questions which has been asked. Of course, the options are not complete because we can't do that because these questions are purely based on how we have recalled it. Questions are somewhat similar to what we have faced it. This is going to be very much short and crisp because I don't want to delay it. You guys will be like you are waiting for your parties to be there, and I don't want to disturb it. We'll just finish it off even before the night starts. Let's start with the first question, guys. A patient who is under doxorubicin therapy. I hope it's clear. Good. A patient who is under doxorubicin therapy reported with toxicity symptoms. Which of the following can be given to treat his condition? A direct question, which many times has been seen previously, guys. So, doxorubicin comes under a class of anti-cancer agents called as anthracyclines. Doxorubicin comes under a group of drugs called as anthracyclines. We all know that anthracyclines tend to produce free radical damage to the nucleic acids. What free radicals will be released? Iron free radicals is going to be released out, and these iron free radicals will be binding with the cancerous cell nucleic acids, breaks it down. Once it is getting broken down, what will happen to those free radicals, guys? It will be released out. It will be targeting the cardiac muscle cells, which leads on to cardiotoxicity. So here we have to give a drug which is primarily because of iron molecules. So we have to opt for an iron chelating agents. See, all these guys are not new, buddy. All these guys we've already dealt with that in major, and very much happy that majority of the questions were taken up directly from the notes itself. Very much happy for that. As usual, majority of the questions are directly from our notes itself. So we have to opt for an iron chelator agent. So this question has to be converted to an one-liner, and that one-liner is, which of the following is an iron chelator agent? We opt for dexrazoxane. Here we can opt for dexrazoxane. Polyethylene glycol is not a drug which has been administered. It is given along with certain drugs so that these drugs can reach inside the bone marrow. Amifostin is unlike one. It's a radioprotective agent. It can be used to prevent radiation-induced xerostomia. Pilocarpine, the same concept. It will prevent radiation-induced xerostomia. We'll move to the next question. So the answer for this question is going to be dexrazoxane. The next one, the tyrosine kinase inhibitor approved for treatment of a patient with bleeding manifestation and petechial rashes. Guys, this is the question which I got from the students again. So very much glad. Thank you for those students who came up with those recalls. We'll start. The question is totally direct, guys. For example, if the question doesn't contain this particular terminology, because initially I got a question like, without this terminology, without tyrosine kinase inhibitor, which of the following drugs can be used for thrombocytopenia? If that is the question, we can go for fostamatinib, we can go for oprel, we can go for L-Trombopag. But the question has got confined to a single answer, and that sentence is going to be tyrosine kinase inhibitor. So with this simple concept, tyrosine kinase inhibitor, we all know that the drug's name is going to be ending with TNIB. TNIB means tyrosine kinase inhibitor. TN means tyrosine kinase. IB means inhibitor. So we have two TNIBs here, fostamatinib and bosutinib. Not only bosutinib, even your nilotinib. We also have imatinib. All these TNIB agents, especially these drugs, are approved for CML. Prolongation is an interleukin 11. This drug is going to be acting at interleukin 11. L-thrombopag. Thrombopag means it's a thrombopoietin agonistic agent. It's a thrombopoietin agonistic agent. So with this, we have cleared up all the three options. And of course, the drug which can be used for thrombocytopenia are fostamatinib, we have oprelvecin, we have L-thrombopag and thrombopag. But one drug which has to be a tyrosine kinase inhibitor, please remember this body, the answer is going to be fostamatinib. Beautiful. Moving on to the next question. A patient presented with diarrhea after 3 days of amoxicillin therapy. Which of the following drugs is approved for this condition? I hope this was the question which we have faced before, buddy. If you have any doubts in that question, please put up in that chat box. I'll be very happy to answer that. Yes, yeah, I'll just proceed with this question. If there is any issue with the question, like small changes in the options, you please put up in the chat box. We can just easily come up with those answers. A patient presented with diarrhea after 3 days of amoxicillin therapy. Which of the following drugs is approved for this condition? So here they're not asking about the drug of choice of this condition, buddy. The question is directly targeting which of the following drug is approved for this condition. We have ampicillin, gentamicin, fidaxomicin, and one more option. So anyone who can come up with those one more option? If you have in mind, we can come up with the other option, buddy. Yes. If you have any other options in your mind, because if there is vancomycin, then the whole answer is going to be totally haphazard. I hope there is no vancomycin in this question. There is no vancomycin or there is no metronidazole. If metronidazole is there, it's totally out of the phenomena. No need to worry. But if there is vancomycin, there might be an issue because the recent statements from the Harrison tend to state the treatment of this particular condition is vancomycin bar fidaxomicin. Good. I'll just consider this as okay. Thank you so much. So it is not vancomycin. Option D is not vancomycin. So the answer for this question is going to be fidaxomicin. Why is this? What exactly is this condition, buddy? It's because the patient has landed up in 3 days of amoxicillin therapy. I hope you remember that mnemonic, right? 1C is caused by 1C is caused by 2A plus 3C plus 4C. You remember this mnemonic, buddy? Yep, Dr. Sayak, you're right. Toxomycin is the answer there. This was the mnemonic which we had for remembering those drugs which might induce a particular condition. What are those 2A? 2A includes amoxicillin and ampicillin. Amoxicillin and ampicillin. 3C represents the first C is ciprofloxacin. The second C is cephalosporins. The second C is cephalosporins. And the third C is the drug clindamycin. Clindamycin. 4C stands for 4 cycles, that is tetracyclines. And 1C is nothing but colitis. Colitis is nothing but, that is the diagnosis of this question, buddy. Yep, this is Clostridium difficile associated diarrhea, or we can simply call this diagnosis as pseudomembranous enterocolitis. So converting this question towards a one-liner. So what's the one-liner? Which of the following drug is approved for pseudomembranous enterocolitis? Simple question. And the answer for this question is going to be fidaxomicin. Any doubts till now, buddy? Is there any doubts like Zima, Zeni, or Sayak, or Dr. Jay? Yeah, hi, Dr. Jay. Hi. Good. Thank you. We'll move on to the next question, buddy. All of the following adverse effects is most seen with carbamazepine than oxcarbazepine. A very important question because the question was either was it targeting carbamazepine or was it targeting oxcarbazepine? That was the famous query and famous doubt over here. So we'll start with the question here. All of the following adverse effects are most seen with carbamazepine than oxcarbazepine, except, simply put, which of the following adverse effects is most seen with oxcarbazepine than carbamazepine? That's the basic concept. You remember, again, we had a mnemonic. Remember the adverse effects of carbamazepine? Yeah, bad oath. I don't want to go into the details of it. Everything is there in our notes itself. But the take-home point here is, one important issue is there with carbamazepine, and that is it might produce Stevens-Johnson syndrome. It might produce, exactly, Dr. Sayak, you're right. SAADH is more with oxcarbazepine. That's the answer for this question. Stevens-Johnson syndrome is there is more chances of Stevens-Johnson syndrome and toxic epidermal necrolysis with carbamazepine. But the issue with this is, because of development of Stevens-Johnson syndrome, we have to follow a particular technique called as SLGS technique, start low, go slow technique. We start carbamazepine at an extreme low doses, and the increments is going to be slow, and the gradual increments has to be there for carbamazepine. But that is not necessary for the derivative of carbamazepine, which is oxcarbazepine. Oxcarbazepine is going to be, we can go with fast escalations. That's the most important advantage of oxcarbazepine. We can go for fast escalations. And one more thing, this is the advantage of it, buddy. This is the advantage of oxcarbazepine. But one disadvantage is one adverse effect of carbamazepine is going to be more with oxcarbazepine. Even though it's a derivative of carbamazepine, adverse effect is going to be more than the parent drug itself. And that is nothing but SAADH or dilutional hyponatremia. This is the answer for this question. Again, it's one of the most common questions recurrently been asked. I think for the past 2 times it has been asked in INI CET, guys. So now we are seeing it for the 3rd time. A very important question regarding the differences between the derivative of carbamazepine and oxcarbazepine. Why? Because currently, more than carbamazepine, oxcarbazepine is preferred for trigeminal neuralgia because of faster escalations and a better safety profile. Good. We'll move to the next question. A patient on anti-tubercular therapy presented on follow-up with increased TSH and decreased T3, T4 levels. Which of the following would have caused this? A patient is on anti-tubercular therapy presented with increased TSH, decreased T3, T4 levels. Simply put, it is drug-induced. Yeah, drug-induced hypothyroidism. Drug-induced hypothyroidism. Which of the following would have caused this? Which means which of the following anti-tubercular drug would have produced hypothyroidism? Again, the question is so direct, buddy. Drug-induced hypothyroidism, we have ethionamide. It's again a direct question. Ethionamide, and also we have PAS. We have prothionamide. All these drugs are associated with hypothyroidism, and that is what's seen over here. So this question is, answer is going to be ethionamide. Simpler, a direct question. What about pyrazinamide? Pyrazinamide is associated with hyperuricemia, increased uric acid levels. Pyrazinamide is associated with increased uric acid levels. Cycloserine is associated with the neuropsychiatric disturbances. Everyone knows it. We have revised it at many times during our sessions also. Ethambutol, E is for eye. It produces ocular adverse drug reactions, optic neuritis, and retrobulbar neuritis. Also, it might produce increased uric acid levels. Pyrazinamide also produces hepatotoxicity. Pyrazinamide also produces hepatotoxicity. So here, the question is not going to be it's not a difficult question, guys. It's a so direct question. The answer for this question is ethionamide. I heard that there was one more question regarding pyrazinamide usage, and the uric acid level was raised. What's the next step in management? Again, I'm facing some clear questions like that, but if you have any idea with that, please just put it up in this chat box. We can discuss it further. Good. A patient on cell wall synthesis inhibitor was given a protein synthesis inhibitor. A cell wall synthesis inhibitor was given a protein synthesis inhibitor as an add-on therapy. Which of the following can be expected? Here for this question, I'm a little bit skeptical, guys. So we don't have a clear-cut view of what exactly was the question. But anyhow, a question which was somewhat similar to that was actually asked in your exams: cell wall synthesis in combination with protein synthesis. It's a simpler complex. Again, we have discussed it many times during our exams, during our classes also. Cell wall synthesis inhibitors are mostly bactericidal in nature in combination with bacteristatic drug. A famous thing, right? Remember, if you have a bactericidal drug and you give a bacteristatic drug, what will happen, guys? The static drug is going to be inhibiting the cidal activity. That's the concept here. That is going to be antagonism, and that is the answer for this question. We shouldn't combine a sedal drug and a static drug because there is going to be antagonism. We can combine two static drugs. We can combine two sedal drugs. But if a patient is on static therapy and we're going to be adding up one more drug, it's not going to be working out. Again, if you have any clear-cut idea on what exactly is this question, a question somewhat similar to that was asked in your exam. So I just need that full questions if you have answers. 56-year-old patient, known diabetic. This is an important question, buddy. 56-year-old patient, known diabetic with renal impairment and heart failure. Which medication can be added? 56-year-old old age patients, he is a known diabetic individual, renal impairment. Diabetes with renal impairment, or which drug is safer to be given in renal failure? A famous answer is there, that is linagliptin. Linagliptin is a drug which is safer to be given in terms of renal failure along with diabetes. But here this patient is not only having failure, he is also suffering from heart failure. We all know that even though among gliptins, the saxagliptin and allogliptin, those drugs are there which might worsen congestive cardiac failure. Linagliptin has got the least chance of progression of congestive cardiac failure. We can give that drug even if the patient is suffering from congestive cardiac failure. But if a patient is suffering from CCF, the drug which is more, or the patient is suffering from renal impairment, the drug which can be given is going to be SGLT2 inhibitors. Sodium glucose transporter type 2 inhibitor are the drug of choice, especially empagliflozin will be the treatment of choice. And the answer for this question is going to be empagliflozin, guys. The answer for this question is empagliflozin. Liraglutide, although it can be given, comparatively, we have to choose with empagliflozin, which is going to be more renoprotective in nature. And also for renoprotective nature, we have a newer drug which is approved last year, like the drug's name is called as Finrenone. It is also found to be more renoprotective, especially in patients with diabetes mellitus. Yep. We'll move to the next one. A pregnant third trimester lady on lithium therapy presented to the OPD. No complaints and was stable for the past 1 year. What's the next step in management? Again, this question is direct, guys. This question is so direct from our notes itself. It's not actually direct. We'll explain that later. The concept of this is, I hope you remember that we put up some formula for remembering the volume of distribution. Volume of distribution is directly proportional to age, obesity, lipid solubility of drug, and pregnancy. I hope you remember that. Volume of distribution is directly proportional to all these 4 different areas. Pregnancy means not exactly pregnancy, but it is primarily the trimesters of pregnancy. Yep. As the trimester increases, there is more chance that the volume of distribution also is going to be increased. For example, if you administer lithium, the lithium concentration is going to be this much, and your brain concentration is going to be this much. There is an equilibrium which is attained there. You do therapeutic drug monitoring. For the example, the patient is given lithium, right? You do therapeutic drug monitoring, plasma concentration is this much, happy. Now, when the trimester is going to be increased further, there is going to be increased volume of distribution, which causes decreased plasma concentration. Now, when the plasma concentration decreases because of increased fluidity or increased hemodynamic changes, which happens at the third trimester of pregnancy, there is going to be movement of drugs from inside the brain towards outside the brain. So the plasma concentration tend to increase, whereas the CNS concentration tend to decrease. Remember, previously, this was the concentration. Patient didn't have any episodes of mania. Now the concentration has decreased. The patients might develop an episode of mania. To prevent that, we have to do therapeutic drug monitoring at the third trimester, and we have to increase the dose of lithium. That's the next step of management for this particular condition, buddy. So the answer for this question is going to be increase the lithium dose. We have to increase the lithium dose. Remember, abrupt stoppage of, if there is an option of discontinue lithium, please don't opt for it. Why? Because abrupt stoppage of lithium might produce rebound mania. That's the reason why it is usually not recommended. The lithium dose is not going to be enough, even though the patient is asymptomatic, even though the patient has got no complaints, or this patient is stable for the past 1 year, we have to increase the drug dose. That is the take-home point here. Good, guys. We'll move to the next question. Which medication prevents myocardial remodeling in dilated cardiomyopathy? Again, a very famous question. We have dealt with that many times in our notes itself, and that concept is simple. misbah. What was misbah, buddy? M is for mortality, drug which might decrease the mortality. I is for ivabradin. I is for ivabradin. S is for sacubitril with valsartan combination. Currently, this will be the drug of choice. ARNI. This is what ARNI is. Angiotensin receptor neprilysin inhibitor. Beta stands for beta blockers. A stands for AC inhibitor or ARB. And H stands for hydralazine. H stands for hydralazine with ISDN combination. Isosorbide dinitrate combination. So with this, with all these drugs, which drug is going to be useful to prevent myocardial remodeling? Here we have two different options, which might be of query: carvedilol and an AC inhibitor. This is primarily based on which AC inhibitor is given in this option, buddy. Because if this option is going to be purely AC inhibitor, I will opt for AC inhibitor. But if the option is going to be different, like any pro drugs like captopril or any short-acting drugs, then that will not be the one. Carvedilol will be the one. So this is primarily based on what AC inhibitor was given in your exams. Just as a take-home point, anyhow, for those guys who have finished their exams, if it is AC inhibitor, happy for that. If the AC inhibitor is not there, there is captopril, then we have to opt for one more beta blocker. That's the better drug there. But here the take-home point is AC inhibitors or ARBs or ARNIs, angiotensin receptor neprilysin inhibitor, will be the drug which will decrease remodeling in congestive cardiac failure patients. Good. And one more image. I was hearing that some images was being asked. This was taken up from an article which has been published in Practical Diabetes Journal body. It was in I just took up that image from Bidil K and Ahmad SH. So I just want to give up the references to those guys. Anyhow, I'm just hearing a questions like a question was asked similar to this exam body. So similar to this question. This question was primarily targeting on the mechanism of action of tacrolimus regarding its calcineurin inhibitor property. Regarding its calcineurin inhibitor property, if this question was regarding this, of course, that is the mechanism, because here's what the question is. What was the drug which was asked here? This drug is going to be binding with a particular molecule called as FB molecule. With this FB molecule, it is going to be binding with calcineurin and tend to be inhibiting this particular enzyme. The answer for this question is going to be either tacrolimus or cyclosporin. Here, if tacrolimus is going to be there, that will be the answer. I hope that was the question which was been targeted regarding tacrolimus. This question is primarily targeted on an image which was given regarding the mechanism of action of a particular drug, especially which is an immunomodulator agent. Any leads on it? If we have, you just put it up in this chat box, buddy. We can just clear it out. Any leads which you have with this images like this? Okay. This question was again an important question, buddy. Majority of the patients, major students came up with those confusion with that. A patient was on antidepressant drugs. As an add-on therapy, he was started on a mood stabilizer agent. He was on antidepressant drugs. As an add-on therapy, he was started on a mood stabilizer agent. Which of the following following which he presented with hyperammonemia and raised LFT? Which of the following would have caused this? Again, it's a direct question. I'm going to be changing the question to an one-liner. Which of the following drug is associated with hyperammonemia and increased liver function test, raised LFT values? Direct one, everyone knows that famous mnemonic buddies were everywhere. Valproate, yeah, Valproate was the mnemonic there. And with that, we have A is for ammonia. Ammonia is going to be increased. Hyperammonemia is a common adverse effect which is seen with Valproate, buddy. A common area which is seen with Valproate. Of course, raised LFT. If the question has contained no hyperammonemia, only raised LFT, then I will go with Valproate and also carbamazepine. But if the question is containing both hyperammonemia and raised LFT, so I'm going to be opting for Valproate for this question, guys. Good. Which of the following drugs inhibits ATP binding cassette protein? Is it verapamil, nifedipine, tacrolimus, and option D? See, ATP binding cassette protein is nothing but P-glycoproteins. Simple. Drug which is a P-glycoprotein inhibitor. Drug which is a P-glycoprotein inhibitor, everyone knows. We know that famous interaction between verapamil and one more anti-cancer drug, that is methotrexate. You remember that, buddy? Yeah, methotrexate tends to get concentrated into the cancerous cells. But because of P-glycoproteins, this methotrexate is going to be thrown out because of P-glycoproteins. And this P-glycoproteins is going to be inhibited by verapamil. P-glycoprotein is inhibited by verapamil, and the answer for this question is going to be verapamil, buddy. So drug which is going to be inhibiting ATP binding cassette protein or inhibiting P-glycoprotein is going to be verapamil. Good. A 35-year-old male patient presented to the emergency with altered sensorium and pinpoint pupil. Which of the following would have been the cause? Yes, so direct body pinpoint pupil. It's going to be either, if you just want to target a particular option, you have to look at two major options, buddy. Number one is going to be either a barbiturate overdose or if it's going to be an opioid overdose. The answer for this question is going to be direct. It's an opioid overdose. Morphine overdose is the answer for this question. Altered sensorium, pinpoint pupil, morphine overdose. Good. Patient presented with prolonged QT interval. Patient presented with prolonged QT interval. Which of the following drugs is implicated for this? Again, we have one more drug, guys, which is there in the market currently, and that drug disorders dextropropoxyphin. Right? You know why dextro form of propoxyphin is currently there, was actually currently there in the market? Why? Because propoxyphin was the drug which was first found to be producing extensive arrhythmia because of QT interval prolongation. Because of this propoxyphin was currently banned, and because of it, dextropropoxyphin was being used. Even that also is not being used currently because of, again, more chances of QT interval prolongation. So propoxyphin is the answer for this question, buddy. So I hope everyone would have answered this question in a right way. Propoxyphin is a drug which might prolong QT interval. A doctor prescribed amitriptyline. What is amitriptyline? Tricyclic antidepressant for a patient. Next day, he presented with overdose of that drug. Which of the following effects will not be seen in the patient? Hypothermia, arrhythmia, dilated pupil, and confusion. It's a simple concept again. Which of the following is not a symptom of TCA overdose, tricyclic antidepressant overdose? Everyone knows it, buddy. I hope you remember that tricycles, no? 3 cycles will be there and 3 other adverse drug reactions will be there. This was the thing which we used in our classes itself. C is for it might produce coma, it might produce convulsions, it might produce cardiotoxicity, and 3 other adverse drug reactions, which includes alpha-1 blockade, muscarinic blockade, and histaminergic blockade. Tricyclic antidepressants will be having 2 sets of 3 adverse drug reactions. Alpha-1 blockade, it might induce sexual dysfunction and postural hypotension. Muscarinic blockade will produce hyperthermia. Muscarinic blockade, that is atropine, for example. Atropine is an anti-muscarinic drug. It is associated with hyperthermia. It will not produce hypothermia. So this is typically a question regarding which of the following is not an anticholinergic adverse drug reaction. And that answer is going to be again hypothermia for this question. Arrhythmia, yes, cardiotoxicity. Dilated pupil, yes, muscarinic blockade will produce mydriasis. Confusion, yes, that is what convulsion and the coma is going to be seen as related adverse drug reactions. So the answer for this question is going to be hypothermia. And 2 other drugs which we come across, again, we're not that much clear about what questions was actually asked from that. Valproate's mechanism of action. Was there a question, guys, regarding this Valproate's mechanism of action? Yeah, they gave some diagrams, I suppose. I hope again it's direct from our, it's like in one-liner, buddy. We just have to follow up your notes. So we have 2 different options. Valproate inhibition. It might inhibit GABA transaminase and also inhibit succinic semialdehyde dehydrogenase. 2 different enzymes will be inhibited by that. But again, it's an image-based question, so we are still in search of that image. Again, one more regarding the drug of choice for antifungal drugs. This question has been said by many different students. Again, we couldn't get a clearer picture of what exactly was that question. If you come across that question, and it will be displayed up back again, and no need to worry. Full detailed discussion. This is just like a fast recap of all those questions which has been asked today, buddies. So we'll be having a detailed discussion of all the individual questions, and regarding the other options, ruling out of options, a detailed explanation will be there in few minutes or in few days. No need to worry. All the best, guys. You have finished your exams in a very beautiful way. Now is the time for party. I think it's already late. Good night.